Okay. Just by reading out the title, I get nervous. I don't know you, but understanding research data, intention to treat, and related missing data and covariate adjustment. It's like nothing, right? So I said, okay, let's start very easy, very simple, and we will become more and more complicated with time. So this is the easiest and the simplest design you can imagine in clinical research. You have a sample, you randomize it to 2 groups, no more, just 2 groups. Then one gets a new intervention, the other the standard of care, and then you measure, you follow them up, and you get the endpoint, right? Things cannot be this easy. Things can start getting challenged, okay? The first of all, we already mentioned it, is the sample. So sometimes what we get in the sample and how we have to interpret is whether the patients that we get are the typical ones. Is it the people that will actually get this intervention? Actually, aren't they healthier than the normal ones? Because they're, you excluded everybody with comorbidities, so maybe these are not the typical ones. Are these younger than the usual one? So this is what you actually, to interpret whether you have some biases in the sample or selection biases, you go to table 1 in the paper. And then you look at some things. In this case, I have highlighted 3 things that I said, this is not my typical patients at all. These are too long a disease, too active a disease, and they have not taken almost any drug before. So this is something that you need to look at the papers when you are looking at whether they might have some selection bias. It's not really selection bias, but not representative enough, okay? So the decisions that you take in your sample, when you decide on how you will select the patients and how you will sample them, it's going to affect how people will interpret your study. Like, this is not the population I will do that intervention, okay? So that is the first step. The second, it's the randomization. So we've known a few techniques to randomize, but sometimes randomization just might not work. Perhaps because the sequence can be broken easily, or perhaps it was not really randomized, or maybe it didn't work. Remember this morning, Ricardo asked, is this really randomized? Because you were always showing, it was red and blue, I think. And it was just that the sample size was very small, right? So this can happen, right? It is rare, but sometimes randomization doesn't work. In this case, we have 2 groups. In one, 100% are women. In the other is only 80%. The duration of disease in one group is more than 8 years, in the other is 4. And then the reactive, C-reactive protein in one is very high, and in the other is not so high. So what do you think you can do in such a situation? Specifically in this situation, you know what happened? Look at the top. What happened? Can you see anything at all? Yeah. It happened like this morning. The sample size was very, very small. So you cannot do much more. This is what you get. You cannot. If you had got a larger sample size, you could adjust for the differences. Okay? So you will kind of deal the clinical trial like if it were an observational study. In observational studies, in quantitative world, you have to adjust for the things that are not balanced, okay? So you will have to do a multivariate analysis and adjust for these things. Not in this case, because you cannot do a multivariate analysis with 13 patients per group, okay? This is one first hint. Now, actually, there is this blurry, we talk about experiments this morning, right? There is some blurry border between efficacy or intervention studies being experiments and observational. Because sometimes, if we do not have randomization, if everything is unblinded, actually you are having just observational study, right? You are just watching what is happening. And in observational studies, the assignment of treatments is not at random. This is a big, big, big problem, okay? So what can we do? There's no randomization at all. So this is what happens when you want to look at the effectiveness of interventions, but you are in the observational world. Imagine instead of going, because you only have 6 months to do something, to finish your PhD, you cannot start a randomized controlled trial now. So you better go and use some data that is already there, right? So you try to use, this morning I heard about, during lunch, I heard about a huge database that you might have access to. And then instead of drugs, you can put whatever you want in there, okay, whatever intervention. So you want to compare 2 interventions and to see what is the response with the intervention and to see whether the intervention has an adverse event, right, or side effects. It can be because of the intervention, but it can be also because they have other treatments, or it can be because they have different levels of disease, or because of the year, and depending on the year, some other things happen, right? Like COVID years are completely different than other years, or because you are just doing a very tight monitoring on those patients. Maybe the patients that you are following more closely are better off, right? And also regarding adverse events, maybe you get adverse events because they are getting other things. Imagine you are giving a complex intervention with physical activity, very intense physical activity, and also nutrition, and you get some disbalance in some of the groups, right? Also because they might have comorbidities, and imagine you are just giving intense physical therapy to people who have a cardiac disease and you didn't, and you are getting more strokes in one group. Or also because of the tight monitoring, okay, that is unbalanced. So there are many other things that could get in the middle between your treatment and the response, or your treatment and the side effects. And these are not only the things that could get in the middle. You could also get a lot of other unmeasured things, right? So this is the reason why you need to do something with the confounding in effectiveness studies. So what is the problem when you compare groups of treatment and you don't randomize? You cannot use that hypothesis that the groups are equals. I mean, the null hypothesis is that the groups are equal, right? But here, the groups might be equal, but maybe all the other things are different. Okay, so you have no idea whether the effect is due to the treatment or to many other things. So a type of confounding is the confounding by indication. So we treat to give patients specific treatments because they deserve it, right? In real life, depending on the diagnosis, on the severity of the disease, and also on other comorbidities, we give patients different treatments, right? And this is very, very typical of when you want to compare interventions. And it is very difficult to adjust for this tendency of clinicians giving different treatments to people. So do you know how we usually do this? Have you ever heard about a specific technique for this? No? Okay. I'm going to show you another bias. Channeling bias. This means you don't give the intervention to the ones that will have an adverse event. So you don't give intensive physical therapy to people with cardiac problems. You only give it to people very healthy. So that way it looks like intensive physical therapy is very good for whatever you want, right? So this is the same with a drug. So it's like you are giving the treatments to the ones that are going to respond better and that are going to have fewer adverse events, okay? So these two biases, confounding by indication and channeling bias, can be tackled, okay? So how can we do it? First of all, we have to think about what gets in the middle. So remember that diagram, comorbidity, disease activity, all the things that can get in the middle between your treatment and the response, or your treatment and the side effects, okay? All the things you have to think beforehand, not after you are trying to do the analysis, okay? So under the design step, you do some brainstorming. Usually we don't think about the confounding because we randomize, right? But if you think ahead, you can also, if you want to learn more about this, you can do the acyclic graphs, which is basically variable, trying to find the causation or not. Then, once you have the full list of things that could get in the middle between those associations, you can, of course, randomize. This is not correct. This is randomization. If you randomize, then you get rid of all the confounding. You can also restrict the inclusion criteria. That way, if you have the list of confounding factors, you can use them to restrict your sample to the ones that will not get these things in the middle, right? If you do not include people with cardiac problems, then you will not get differences, right? And then you can do matching, only include patients or population that are very similar in all the groups, like you just match them to things that get them similar. But you can do that in the design, but you can also do things in the analysis. One is the stratified analysis, just by different groups, or the multivariate analysis. And this is the technique that I wanted to measure. Have you ever heard about the propensity score? No. This is very much used in drug studies, but it's not only in drug studies. Propensity means that you have a higher chance to give a treatment to somebody who needs it. In real life, it's not, you don't give treatments at random. You just give them tailored, right? So the propensity score would be a way to actually to find what is the probability of you giving a treatment to a patient, right? And then using that information to match or adjust or something. So how do we do this? First, we identify which variables are actually the ones triggering my decision to give a specific treatment, right? So you can either do it statistically, just see which is associated with the treatment, or you can just think about it. Just think as clinician, I'm giving this to patients who do that, or, okay? Then you calculate a propensity score based on a regression model. That means you do a regression model, and then you put as the dependent variable getting the treatment, right? And with a number of variables, you will get, for each patient in your sample, you will get a probability of getting the treatment, right? So you just created a new variable that is called propensity score, right? Once you have that variable, that new variable, you can do it to do things, to balance, right, the groups. And how do you balance them? You can either use this propensity score as a weight, so you put it one divided by the propensity score, the inverse variance of the propensity score as the weight. That means the results that you get, that you have from the analysis will be weighted so that you have the same proportion of patients with the probability of getting the treatment. This is a little bit difficult to interpret, okay? But you just need to look at the results and see whether there is a risk effect, a risk ratio in favor of one or the other group, right? So weight, this is the one that is used the less, okay? This is the one that the statistician like the best, but this is the one that is used the less. Then stratify or adjust. Stratify, you divide the sample into groups, and you only analyze the groups that have same levels of propensity score. You can also use the propensity score to put it as a variable in your model. So when you do the analysis, you just use the propensity score as another variable. And the good thing about this variable is that it contains a lot of other variables. So with just one variable, you don't need to put many more in the model. And the last thing that is done very often is to match. It means means you only analyze patients that are matched to the propensity score level. So you get patients with the same probability of having got the treatment, but they didn't get it. Okay? Yeah.
Sorry. So the propensity score, you use it only after collecting data, and so it's, you collect 100 patients.
Yes.
And then you do the propensity score just to get off the confounders.
Exactly. So
it's like a measure to clean the sample.
yes, it's
the outlier.
yeah. So it's something that you do afterwards when you get all the data, and it's like a new variable that you create afterwards. Okay, because
when we do,
yeah.
when we do linear regression analysis, it's something like this, because or logistic regression analysis.
Okay, you do.
Which are the best responders?
Yes. Okay. So you do regression analysis in observational data to obtain a result, to see what is the association between your treatment and the effect, adjusted by a lot of things, okay? But there is this additional problem when you want to see the effect of an intervention. I mean, if you're looking at other things, there is no problem. You don't need a propensity score. But if you want to look at the effect of interventions in observational data, then you need to adjust by this confounding by indication. And the way to do it is creating a propensity score.
Okay, so for example, you have a truly RCT.
Yes.
And after finishing your work,
yes.
you get only the training group patients, and you do a propensity score to see in this group of patients which are the best responders to the intervention. So the training group patients were better than control patients. But you want to know among the best ones, who are the best responders?
Okay, that's a very twisted question.
So, maybe I misunderstood.
No. It's good that you asked that, because then I understand what the problem is. This is if you don't have time to do a randomized control trial, you just go and get the data from elsewhere. Okay. For instance, imagine that you have a registry of all the patients that you have in your yeah. It's only for observational data.
Okay. You collect data and you see, okay, among all of this,
yes.
Let me see which can fit.
Exactly.
The intervention fits better.
Exactly, because what you were talking about is subgroup analysis.
Okay. Yes.
Yeah, which is not exactly the same. You probably don't need to adjust much if you are doing if you are using data from a randomized control trial. Observational data mess, you need to adjust. And one of the best things, if you are looking at the effect of interventions in observational data, is to adjust for the propensity to. But you have to think in the interventions that you are providing, which are the things that, if you are giving the same intervention to everybody, then you don't need to compare, yeah, right? But if you have different interventions depending on the type of patient or characteristics of the patient, then you need to do this. Before, after, before, after, you cannot really adjust for this, because you are manipulating the intervention. You are specifying when you are going to give the intervention. So in that case, you will have perhaps a problem of selecting the patients, whether they are biased or not, but you don't need to do propensity score for that. Only if you want to analyze observational data that has already been collected and you want to do something with it. Okay? This is not for prospective studies. Okay? Other challenges, very similar to the randomization is the blinded. If you know exactly what is the drug that you have, then you will have the same problems, right? So we already mentioned that blinding is very difficult in complex interventions. But there's no specific thing that I can do in there, except for, being very good at blinding. Next, challenges in the design is the comparators. Is it a fair comparator or not? And here, we haven't talked much about this, but you probably know whether there is a different probability of getting a good result if you compare to sham intervention than if you compare it to doing nothing. If you compare anything to doing nothing, everything works. Yeah, even Reiki, praying, whatever, it works. Yeah? If you compare it to placebo or sham, that is not so, I mean, you can still get a lot of effectiveness, yeah, right? But if you compare it to another treatment, then we get into non-inferiority, equivalence, that is very difficult to actually compare. So you have to think, okay, I will not compare with something that I need a huge sample size to test, to find a small difference, but I will not compare it to doing nothing. So you need to compare it to something like the standard of care, yeah, if the standard of care is not doing nothing, okay? But how you interpret the results, I think this is something that many people don't get right. It is very easy. If you get a p-value below your significant value, 0.01 or 0.05, whatever you stated, then it is probably that the treatments are different, right? But if you get a non-significant p-value, what do you need to do? Sorry, I need to move. If you don't have enough statistical power, then your results are inconclusive. You cannot say that this doesn't work or that this works. It's inconclusive, okay? Now, if you have enough statistical power, that means more than 80%, then you can almost say that there are no differences between the treatments. But to say that, you need a huge sample size, okay? Either that or the effect is so small as the placebo, yeah? So it is, if you have a non-significant value, never say that it doesn't work. First, check if you have enough power to say that. It is safer to say it's inconclusive results. Okay? And then when Ricky and myself go there to do the systematic reviews, maybe we can do a meta-analysis, and then it will not be inconclusive at the end. Okay. More challenges. We lose people to other groups or even outside. That would be attrition bias or moving around, like I was in the standard of care, but I saw these people doing mindfulness, so I will do mindfulness as well. Yes? This has happened to me many times. Now, what do you do when this happens in a clinical trial? Exclude? Punish? I try that, but I have to keep the researchers in my team.
If they drop, it's missing data. Right?
If they drop, it's missing data, okay. But
they change the group, probably my first answer would be exclude the result because it's contaminating the results. I guess.
It maybe depends on the intervention. For example, if it was only once,
if it's only once.
For example, this was mindfulness, probably the results would be contaminated, I think. So.
They're going to get contaminated, right? So,
it will also depend
on the number of dropouts. Okay, so we have three problems. We identify, we have missing data, we have dropouts, and we also have contamination between the arms, right? So one of the things that can happen is that the follow-up is incomplete, right? So one of the things we have to understand is whether the groups are dropping out differently. So if we have a group in which everybody is dropping out, we have to understand why is that happening, because probably this is terrible to do this intervention. I don't want to go to that nasty nurse anymore, okay? Or whatever it is, you have to understand why this is happening. Because maybe you can say that that's inefficacy, right? Or that is a side effect, okay? But then what you can do is, for instance, a sensitivity analysis. But another thing that you could do is what is called intention to treat analysis. What is that? Do you have this expression in Portuguese, throwing stones to your own roof? Something like that?
Something like that.
Yeah, something like that. Science is about that. So you have to put a lot of sticks in your wheels, throw stones to your own roof. If the building stays, it means that your design is good, and that your hypothesis is good enough. So throwing stones to your own roof means that you randomize them to group 1 or to group 2, and even if they move around, you analyze them where you randomize them. What is doing is actually balancing the groups, the results. Imagine that mindfulness, it rocks, right? But a lot of people in the standard of care actually went to mindfulness. So in standard of care, I'm going to get a lot of results, good effect, right? So at the end, the two interventions are going to look similar. So if they still are not similar, I mean, if mindfulness is still good, that means that my hypothesis was correct, right? That mindfulness is better than standard of care. So intention to treat means I randomize them to group A, and I'm going to analyze it in group A, the effect, even if it went to the other. Okay?
But you analyze it separately?
When I
Compare the groups, or you, for example, 3 patients for the group 2 pass from to the group 1.
Yes.
You analyze the 3 persons in the group 1. But imagine if at some point you have a lot of people in the mindfulness group and not so much people in group 2.
Then
it's to compare these 2 groups, or
then it's a complete failure of the study, and that happened to me before again. Yeah. Yeah.
But we do it, or
the correct thing is to say the intention to treat analysis shows no difference between the groups because the effect was the same in the 2 groups. But if I do what is called a per protocol analysis, which is I only analyze them where they actually were, maybe the effect shows in mindfulness, right? But as a good scientist, I have to report in a randomized controlled trial the intention to treat. This is what I have to show. Why? This is what we said this morning about the procedures. So you have to be exquisite with the procedures. Very, very, very good with the procedures. Okay? It's the problem is the money sometimes, right? That's why all the people in mindfulness, they shuffle around. Yes, so intention to treat is good science. In a randomized controlled trial, you analyze the person, the patient, in the group it was there. However, that is for the effect, okay? Yep.
So, for example, so if we have a behavior, for example, program, and you have 3 patients that didn't went to the last session of it, you still analyze, you do both analysis with them and without them. And
Yes.
if the results are the same, you assume that the
No, if you want to do good science, you do intention to treat. You assume that they were adherent.
Okay, so you analyze them in the
Yes.
original group and you still compare them.
Yes.
And, okay,
Yeah.
so knowing that you have, for example, 3 patients that did not complete totally the intervention, the intervention is still better than controlled.
Yes.
Okay. So
If that stays, if that remains, if the intervention is still better than the control, it means that yes, your house
but
is
you don't
good
need
enough.
to present the results without
You can present both results. Yeah, but the one that counts is the intention to treat. In fact, if I do a meta-analysis of all the different studies that look at the same intervention, I'm only going to take the raw data. I'm going to take how many you included and how many got defect. So that's intention to treat. Okay?
So, sorry, first of all, the aim is, well, if everything goes as it should, the results should be the same because when you compare the protocol and the intention to treat, right?
You don't compare them. You present the intention to treat and the per protocol. So the only problem with the per protocol is you have fewer patients. But in the case of side effects, for instance, it is relevant that you present the per protocol, right? Because if you balance the adverse events between the groups, then you are not throwing stones to your roof. You are putting flowers in the balcony, right? For adverse events, you do the per protocol, okay? So you analyze in the group they finalize, okay? For adverse events. But for effect, the intention to treat. Yeah. No, as many as you want.
But for example, imagine that you have two groups of patients, 50-50.
Yes.
And the 50 of the training group did everything right. So
yes.
you don't have any dropout, any loss to follow up. So you stated this and you don't need to do intention to treat analysis, or it's...
You will do it. Yeah, it's automatic.
Okay.
Yeah, it's automatic. Yeah. So ideally...
When you state no loss to follow up or no dropout, you're assuming that you have an intention to treat with all of the patients engaged in the study?
If you finalize a randomized control trial with no losses, I mean, I will hire you. Yes. Okay, let's go to the next challenge, which is what I call the cheese part. So you go and try to measure, and then you get missing data. So this happened, of course, in randomized control trials, but especially in observational data. So if you have a lot of variables, you will have a lot of holes in your cheese or your data. Also, if you have a very long study, you will also have a lot of missing data. Just imagine one date. So the patient can enter the data, can go to get lots taken, for instance, or can do some walking or Fitbit or whatever, can enter in the clinical record, can enter in a data collection form, CRF, can tell it to the doctor or to the nurse, the data collector, and then the data collector can simply interpret what the patient said and put it in the clinical record or the CRF. So even in that interaction, you can have a lot of interpretation in the data. Then once it's in the CRF and goes to the file, there is a monitor. Good thing to have a monitor, yeah, that checks the data and says, yeah, this is wrong, you have missing data here, you have outliers, this is not possible. Go there and check, okay? But then when it goes to the statistician makes assumptions, and maybe they create new variables, and some data disappear. Yep. So this is something you have to take into account. Because sometimes the holes occur because the patient didn't want to respond. This is not good. What would you do if the holes are because the patient didn't want to respond? What? Is it not? Could be a problem of adherence, yes, but it could be that the question is, yeah, very provocative or something. I don't want to say anything about the money I make every month, yeah, or something like that. Or I don't want to tell you because you are the one who are going to give me the treatment, so I want to respond in a different way. Or maybe the patient didn't have to respond. Oh, I have a lot of missing data, but oh, yes, it's the men. They are not responding the time of their menopause. Yes, okay. They don't have to respond because they are men. They are not women. Perhaps it wasn't easy to recover that data, or they don't know where to find it, or the responses were so complicated they didn't know which one, so they said other or, yeah, out. So when the response or the data, the specific field, the variable is not easy to recover, maybe you get that as well. Sometimes it's just an intention. So this is the easiest one because you can go back and just check, right? Maybe you missed entering the data. But other times happens, this is terrible, when you are cleaning the data. You are creating new variables and then you create a new variable in which you miss some of the people because they were wrongly imputed. And they can get lost, right? So why is this so important? To avoid missingness as possible, because you can get results that are not the right ones. You can get standard errors and confidence intervals that are not the correct one. And of course, this affects also the significant test. So how to deal with missingness? Ricardo, please tell me when okay, because I have Spanish time here, Portuguese time, otherwise. Okay, so we have four times where we can do something. Best of all, to prevent, right? So what can you do to prevent? Not to have too many variables. The more variables that you have, the higher the probability to have holes in your data. The questions and the responses have to be very clear. We talk about feasibility study, but I always do a pilot of my data collection forms just to make sure that the other is understanding what I want to get into that form. So instructions and pilots. And then if you are doing an electronic collection of the data, you can have alerts so that if you enter some data that is completely out of range, it says, poops, you cannot get that in there. Diagnosis. You have a monitor. You need a very pushing monitor. So if somebody in your team is very pushing, you just assign this person to be in monitor, right? Because if you put somebody like me, everything will be with holes. I accept all the holes in the world. So they have to check the data collection form, the CRFs, versus the clinical record to see whether they can actually collect some of the data that is missing from there. This is very important, speedy feedback. So if you wait 2 months to tell somebody, oh, we are missing a variable here. Yeah, I cannot get that patient anymore. I cannot find that anymore. So it has to be very fast, okay? And then once in a while, just run tables to see whether you have some missing data. This is something that usually doesn't do the monitor, but sometimes the data manager. In my team, it is the same person, the one who does the analysis, who monitors, who does the analysis, everything. Yeah. Then, the first aid is to understand what is the pattern and the level of missingness. What is the pattern? We have several patterns of missing data. What we call the scatter pattern is if you have one here, here. That was a fly. And then another there, right? But then we have monotone, which is one full visit is missing, and perhaps this one is a dropout because I don't have neither the first nor the second visit, right? So it is very important if you see the pattern to understand what happened to this patient. To the others, the scatter one, well, maybe was some unintentional, right? But if it's a monotone pattern, you need to understand whether that's a dropout or not, and to understand what is the cause of the dropout. If the patient died, that's might be related to the intervention or not. Then is the level of missingness. So it depends on the variable, of course, but in this variable, we have 10 patients in my study. In one, variable 3 is missing, so we have 10% of missingness. In variable 1, in first visit, we have 40%, 20%, 20, 30, 20, okay? So what is a lot of missingness or percentage of no response to a variable? I mean, it depends on the variable. If it's just a descriptive variable or a secondary variable, it's not a big deal. But if it's the outcome variable, oops, over 40% might be very difficult to solve, right? Then the percentage of incomplete cases. This is more important for surveys, for instance, than for clinical trials or anything. Incomplete cases is the percentage of cases without data. So less than 2 visits, we have 10%, okay? Less than 3 visits, we have 20%. Now, my question to you. Imagine variable 3, okay, is the endpoint. The endpoint is the variable 3 in visit 1 minus variable 3 in visit 0, okay? So it's percentage of change. Imagine this is a scale. So I want this scale to get lower in the second visit. So what is the level of missiness for the endpoint, which is actually a combination of these two variables? What do you think it is? Is it 20%, 10, 30, or more than 30? 30? 30? Yeah, I think I see a lot of red, yes, because you have actually, you cannot calculate this one, right? You cannot calculate this one either. You cannot calculate this one, and this one. Yeah? No, sorry, no, this one you can, yeah, sorry. Only this, and this. So it's 30%, right? So this is a problem for the outcome variable. For the other variables, it's not that big, but for the outcome variable, it is.
Sorry.
Yep.
Just to be sure, because it's cumulative, right?
It's?
Cumulative, it cumulates.
It cumulates. Yeah, of course, if,
3 different patients.
yes.
For example, if it was the same.
Because it's 10 plus 10 plus 10, that's why it's 30. Yeah.
Yes.
Just
It's,
to be sure that.
yeah, you got it right. Yeah. I didn't understand what cumulative meant. Yeah, but yes. So you know the pattern and level of missiness, but you can also try to find correlations between variables, because sometimes if two variables are very highly correlated, you can guess one variable from the other, right? This is something that you do if you're a statistician to make sure that the missiness can have some solution. Okay, and
I'm sorry.
yep.
You can use some average to put in this missing data, or no?
This
Because I saw
no.
someone
Yeah. This is what we are going to get right after this. The last thing you do before you go into treatment, which is what you were thinking, it's to check the cleaning process before you go further. The cleaning process is that whatever you do to the data, you keep track of it. Even if you clean the data in Excel, you explain what you did with the data. Why do you have a hole in there? Okay. Usually, I use Stata, and I just keep log of whatever I'm doing, and then I try to go back. If I have some missing data in a variable, I try to see, okay, I created this variable. Oh no, the interval, I forgot to include 0.5. And then I'm only including some patients, and then I got a variable without enough patients in there. Or I included some formula to create a new variable that it's getting me this problem. This is very typical when you have, for instance, a variable that is, right? Yes. So the difference between a variable in visit 1 minus visit 0, right? And then you convert that into a response, yes, no. Because this one is a continuous variable, right? This is a scale minus a scale, you will get a continuous variable. But then when you do the dichotomous variable, sometimes you make mistakes in the interval, right? And you get holes in this variable. This is very typical. Most people don't realize that happens, but it does. So you just keep a log of what you did so that you don't miss in there. And now to the treatment. What do people do? Sometimes they say, okay, we will only analyze the ones that we have data. That's called complete case analysis. We will input something in there, like the mean or some other variable. We can do something that is called multiple imputation, or we can do more complicated things. I'll just leave the names in there. So complete case analysis, you only analyze the cases for which you have data. The problem is that this gives you an unbiased result only if the data were missing at random, like, oops, I forgot to put the data in there. But if you are missing the data because of something, like the ones that are not non-adherent, then that's a problem. Because the ones who are non-adherent are different than the others. So if you have holes in there, then it's a problem. Okay? You cannot just analyze the one who were adherents, because then your intervention is going to look fantastic. But perhaps your intervention is a lot of a burden for a patient, right? That's the reason why they are not adherent, right? The other one is the most common one, the single imputation methods. Perhaps you heard about the last observation carried forward. So if I don't have visit 2, I can move visit 1 to visit 2, right? I move the result of one of the visits to the next. You can also impute the mean, yes? So you see what is the mean in that variable, and then you put in the holes the mean, or some other variable eaten on a scale, okay? What is the problem with just putting one value in there? If you, for instance, here, if you have these values, you have 3 values, okay, and then 3 missing. And then in those 3 missings, you put the mean. This is going to change the variance because it's going to be very much homogeneous. So your confidence intervals is going to be smaller and it's going to look much better. I mean, a lot of people does it, right? Do it. So you should not impute just one value. So there are other things that you can do, of course. You can do a sensitivity analysis saying, okay, in those that are missing, I will say they all failed or they all responded, okay? So you do the analysis and see whether it changed a lot. If it changed a lot, then you cannot do much. I don't know what you can do, but you are in very big trouble. Other people define a missing category. Like they have response is 1, non-response is 0, and then 9 is missing, right? The problem is, if I analyze that, what does that mean? What is the effect of missing? I don't know how to interpret that, okay? And if you put that into models, then it's even more complex. And then the expectation maximization algorithm, I have no idea what that is. I'm not a statistician, to my disclaimer. But I know multiple imputations, and I like this very much. Okay, multiple imputation means not that you are going to get one date in there, you're going to get a cloud, okay? And this cloud of values, actually, you will never see them. You are just going to repeat the same analysis with different levels from that cloud. And imagine, here I put a variable that has, that is continuous, but you can have, for instance, you can have sex missing, right? And you can have 1, 2, but the cloud, in the cloud, you can have a value that is 1.3. In sex, what's 1.3? I know 1 is man, 2 is woman, 1.3 is part of my cloud, okay? So these imputations, what are doing is that you are repeating the model as many times as you impute values in the missing values, and then you get confidence intervals that takes into account the noise of the missingness. So at the end, this is only to get better confidence intervals. You are going to get some difference with the real one, depending on the level of missingness, but what the multiple imputations are doing are to increase the confidence intervals. Instead of reducing, like the single imputation, they are going to increase the confidence intervals. Yeah? Is this the first time you hear multiple imputations? Okay, some no. Okay. So just in case, if you have missing data. Of course, you need a statistician for this. No. And then for these other methods, you do need a statistician. So, in summary, simple designs are not always possible. I feel so sorry for nurses and because drugs are so simple. Yeah, like you put the drug, right? But yeah, you cannot put a complex intervention, and see what happens. You need to know, even from the basic designs, the conflict points. You try to make the best to select representative samples and to get them all in, right? If you cannot randomize, or because you have problems or whatever, or because the randomization went wrong, you can adjust for the variables that are unbalanced, or you can create a propensity score. This is mainly for observational data, retrospective data. Okay? Be good at blinding, or if you cannot blind, I didn't mention this, but this is also very important. If you cannot blind, try to use a very objective measure, something that it can be measured very easily, right? Like death is very easy to measure. Well, yeah, most of the time. But I don't know, something that can be measured from a registry, or for instance, disability earnings or something like that. I don't know. Try to find something that is hard measure if you cannot blind. Then choose the comparator wisely. You cannot compare to doing nothing. You have to compare to do something better than nothing. Follow the intention to treat principle, okay, if it's a randomized control trial. And try to keep people in, because preventing missing data is better than any other method, okay? Oof, that was a very difficult one. Thank you. Oof.